Two more questions. One is the importance of tumor boards. And we talk about the team approach. I mentioned in the first segment that lung cancer treatment is not a one woman or one man show. It's a team. Can you guys layer in some perspective on the importance of tumor boards?
Yeah, well, I think it's immensely important because it really hones in on that whole multidisciplinary team approach. Not only that, it gives a fresh set of eyes to look at this picture.
Yeah.
You have the doctor who knows the patient best that could provide some insight into their preferences and how they feel and their performance status, but also a lot of other people looking at it. As the pulmonologist, we're there oftentimes with making the diagnosis and then help with the palliation of symptoms afterwards. But from my eyes, I can't think of anything more important than that.
Yeah. I think it provides a forum for the communication that's needed too. I mean, every patient that I have that is considered for a clinical trial or there's a nuanced treatment decision, these multidisciplinary tumor boards really provide an open forum for different perspectives that you normally wouldn't get. Certainly having the pathologist there is very important, where they can give you some nuances. We've had plenty of times in multi-D tumor board where the pathologist says, look, this looked like an adenocarcinoma, but it's favoring now more squamous cell. So it gives an opportunity to really think in a different direction.
Right. And I think it adds a layer of trust as well from the patient, knowing that their case is being presented.
Yeah, I think that patients like hearing that there's going to be 20 doctors in the room discussing their case, and we're going to try to render some sort of decision. The last question, which I think is important to touch upon, is just what do you think the challenges are with making a diagnosis? You mentioned some of these. I mean, maybe we can go back and talk about the ones that you think are most important. But what are the real challenges? I mean, I think community oncologists and even academic oncologists are facing challenges getting the tissue that they need to make the diagnosis in a timely fashion to deliver the care quickly. Right. A lot of these patients are sick. And I hear over and over again how challenging this can be. So maybe some of this may be looking back and summarizing some of the things we talked about, but in your mind, top level challenges of tissue procurement, making a diagnosis, and molecular testing.
Right. Yeah, I think from the procedure side of it, I can comment is that you're right. A lot of the newest techniques, or maybe they're even not so new, aren't available everywhere. And for example, EBIS bronchoscopy or just staging by bronchoscopy has become almost widespread and has almost replaced mediastinoscopy completely with a good positive and negative predictive value. But there's certainly places out there that still, they don't have that option. They still do mediastinoscopy, and that's a fine approach. It's not wrong to do it that way. Yeah. But as far as the concerns with minimally invasive procedures, the positives are they're minimally invasive, low risk of bleeding, well-tolerated outpatient, can oftentimes be performed with moderate sedation or less anesthesia than is needed for surgery. But the negatives are you oftentimes don't get morphology. Right. So for things like lymphomas, that can play a big role. For lung cancer, it's to be seen. A lot of the latest studies show that we get adequate sampling for a lot of the molecular panel and mutational testing, but that's still a concern. Another concern is tumor heterogeneity. So what you sample in a lymph node or the primary and where you test and send the markers, how do you know that it's really showing the full picture? Yeah. So, and then finally, I think being at two different places doing interventional pulmonary, how important that communication is with pathology, because really this couldn't run without a really good cohesion between the two to know in processing and tissue procurement and how it goes down that pathway, I think is immensely crucial.
Andrea, from your perspective, pathology, big challenges, 30,000 foot overview?
Cytopathology in particular is very difficult. It requires an extra layer of skill on the pathologist. We also utilize cytotechnologists to screen a smear of slides looking for that rare malignant cell that may be hiding amongst a lot of benign cells. And the whole processing, making of a cell block is not straightforward, and it's not always while the material is there, it doesn't always show up in the cell block if you don't have a laboratory who's trained to do it correctly.
I think we've adapted our practice multiple times, depending on what works and what hasn't.
Yeah.
It's kind of a little bit of trial and error as well.
I think that's what it takes, some trial and error to figure out best practices, because while we may have some data to guide us, I think this highlights and underscores the importance of the communication, to understand what the challenges are and the hurdles are, and then redirect and get over that. I'll layer in an additional challenge, which is the advent of liquid biopsies. And how to use these. We've got some new technology that can isolate circulating tumor DNA in the blood from a lung cancer, not only isolate it, but sequence it. And it's been a nice welcome change that can kind of leverage or at least overcome some of the hurdles that we have mentioned here. But I think we're starting to learn that it's an imperfect technology, and some of the information it may provide may not be relevant. There's no doubt that liquid biopsies are important and can be used in certain scenarios, but how to use this and how to use it with tissue, I think is hot on everyone's mind in terms of how to do both of these or just one of them to make sure that we have the right diagnosis for the patient and in a quick amount of time.
And I think the liquid biopsies are going to be limited in what you can get from them in terms of tumor mutational burden.
That's right. PD-L1, that's exactly right.
Confirming that it's actually a lung cancer
That's right.
and not a metastasis from some other site.
That's right.
But once you have a diagnosis established, it's very useful for following the patients during treatment and for recurrence, I would think.
Yeah, I think the longitudinal sampling of ctDNA, while not ready for prime time, is going to be there soon, and then detecting resistance. But there's a lot of things that can happen in that complex biospecimen that you're trying to interpret the results from. So. Well, this has been a very informative discussion. The perspectives you guys have provided from a pulmonary standpoint and a pathology standpoint have been really unique and I think meaningful. Again, underscores the importance of how we all must communicate and how this is really a team approach. We all work together at a center, and we probably talk to each other quite often, maybe more often than we'd like to, but we enjoy it, and certainly it allows for the facilitation of really excellent patient care. So I want to thank you guys for joining.
Thank you.
Thank you.